right, today's video we're going to be going over the documentation for a physical therapy evaluation. So from our hot box, we've got to click the patient that we want to document on. I've only got one here, it's a test patient. So from our hot box, we're actually going to hover over the patient's name and click on it. So now we're inside the PT evaluation. I'll start at the very top here just so we can familiarize ourselves with a few of the identifiers with this document. So first, you need to make sure this says PT evaluation at the top. If it says something else and you mean for this to be a PT evaluation, you've been scheduled the wrong visit. So that's something you want to definitely call our front office to get worked out right away. Right below that, you should see the patient's name and a patient identifier to the right of it. Just below that, we've got the patient identity confirmed box. This box has to be checked. If for some reason you leave this box unchecked, we have to send it back to you to get it checked because it's a required part needed for Medicare. Just below that, we've got the time in and time out. We have to use military time within inside of this software. So this is a 45-minute visit, same between 9:03 a.m. and 9:48 a.m. The visit date. It's a very good idea to open up the calendar and actually physically pick the day. It's a lot easier for us to remember instead of what day of the month it is, to actually remember what day of the week it is. So as long as you know you're on a Thursday and you're documenting in the patient's house, you'll always land on the right date. This seems like a simple, kind of easy thing to just brush over, but we have a lot of documentation that's actually submitted back to us where the visit is plotted for, say, a Tuesday, and the documentation shows it coming through on a Wednesday or Thursday, and therefore the target date and the actual documentation date don't match, and they have to match. And so it's very important that whatever day inside your hot box that the visit is scheduled for is also the same day that you're saying you documented it for. And so usually use this box here. It's pretty helpful. We don't need mileage. We don't keep track of it. If you have been seeing patients for several months, then you probably have some templates in place. I highly encourage people to use templates. It will speed up your documentation dramatically. So let's say you've had, a right total knee. You could just click on this right total knee from a previous patient where you'd saved it as a template, and then all you need to do is make changes to make this patient that you're actually on today be specific from the one you previously documented on. So, but it'll cut your documentation time if not more. And so we're going to jump down. This is all pre-filled here, the G codes. You don't need to worry about that. The first thing you're going to start documenting on after the time in, time out, and visit is the medical diagnosis. This always needs to match the diagnosis from the home health agency. We are to never guess at what this medical diagnosis is. If we don't know what it is, we can leave it blank. Leaving it blank is better than guessing. But it's always a good idea that if we know what the medical diagnosis is from the agency, sometimes they give this to us when they submit the referral to us, to go ahead and put that medical diagnosis on and the either onset or exacerbation of it, and then the date in which we received the referral or the date in which the diagnosis was met. On PT diagnosis, we need to be good about putting this in place. A lot of times therapists will leave this blank, and really we need to have something here. You can generically put in muscle weakness or abnormal gait. I've put both of them here just for illustration purposes. Either one of those work, and they're both very generic in fashion. Home health agencies and Medicare auditors who actually look at this documentation would like for it to be as specific as possible. And so we encourage everyone to get out of the habit of just using generic or leaving it blank. And it's a simple process. You go to Google, I typed in common ICD-10 codes, and here is a list of all the ones dealing with joint pain and limb pain. And so let's say this patient came over and we were seeing them for pain in the right hip. You could cut this ICD-10 code, go back into your note, paste it here, just like I did here for pain in the right hip. And then that way it's more specific than just saying muscle weakness or abnormal gait. So if you know why you're seeing the patient for not the medical diagnosis, but if you know what PT diagnosis you're looking for, you can do a simple Google search, find out what it is, put it in. It looks a lot more patient specific when we do that. Same thing, we need is this a pre-existing condition that we're having an exacerbation of, or is this an initial onset and then a date? Relevant medical history. So this generally comes over from the home health agency when they give us the referral, but it's always a good idea to take whatever they give you and make sure when you're interviewing the patient that it all matches up and see if anything's missing. So in this situation, if we were told from the home health agency they had hypotension, AFib, GERD, and history of falls, I would make sure that's all accurate from the patient. Sometimes you'll find out some of this isn't accurate. And then I would follow up and say, any other surgeries, anything else you want to add to this? Is there anything else that I need to know about? And more times than not, I find out that there's a lot more that I didn't already know about. And that's why it's important to ask that because you can get a more complete story and maybe it'll change your plan of care. Prior level of function, we see a lot of times therapists wanting to put down, just independent with all acts. And we're getting not getting in trouble. We're getting more and more pushback from people who audit these charts, saying that everything needs to be more patient specific. So in this situation, modified without transfers and ambulation within home, uses a rolling walker outside of home for safety. We want to give the person who's auditing these charts we want to give them the clearest picture possible of what's going on with this patient. And so the prior level function and the patient goals need to go hand in hand. We can't say the patient's prior level of function was ambulating 200 feet, rolling walker outside of home, and then in the goals have them walking 1,000 feet outside of home without a rolling walker, because those two things wouldn't match. Whatever their prior functional level is, their patient goals should be striving to get back to that prior functional level. And also inside of patient goals, moving on from prior level function, moving down to patient goals, this needs to be as patient specific as possible. So if the patient says, prior to whatever the event was that caused us to have therapy in their home, they were walking inside of Walmart without an assisted device, and they say they want to return to that, we can actually write in the patient goals, patient wants to return to walking in and outside of Walmart unassisted. So, or patient wants to be able to wash a load of laundry unassisted, or anything else that we want to put in there, but to keep it as patient specific as possible and as detailed as possible. Sometimes we have underneath patient goals, we have submitted back to us, get stronger. Increase strength. That in itself is too generic and too plain for it to pass going forward. We need to make sure that we have enough content here where everyone fully understands what the patient's goals were. Precautions, fall, or any of the precautions you want to have. It's a hip replacement, hip precautions, back patient, back precautions. Homebound, this box has to be checked. Regardless if we're going to see this patient for therapy or not, we have to check this box. And the reason why is if we check that this patient's not homebound, we are speaking on behalf of every discipline involved with this patient. So let's say this patient has something going on where they require a nurse to maybe change a bandage for a wound, or they're monitoring some medications, or doing doing some sort of blood work for the patient. We want to make sure that we don't alter them from being able to go out and see the patient. And if we check the patient's not homebound, we actually could be speaking on behalf of we would be speaking on behalf of the nurse in that point, and therefore they wouldn't be able to go out and do what they need to do. So regardless if they need therapy or not, we always want to check that they're homebound, and then any reason below here that applies. And if another reason outside of this applies, you can always click other and type it in. And in this situation, 4 of the 6 pre-labeled reasons applied to this patient. So always make sure you click this box, very important. Social support, this is all pretty straightforward. Who the patient lives with, how often they receive assistance. Always good to add some content here. Spouse is the primary caregiver. Patient's son comes 2 to 3 times a week, handle finances, and drives patient to MD appointments. Any safety, sanitation hazards, always something good to be looking at as you're walking into a patient's home. Are there any steps? Are there handrails? How easy to get in and out of the house? How easy is it to get to and from the car? Are there pets? Is the 4 unsecured? And then whatever you have that you need to document it here. Getting down to vital signs. We've gotten the habit of doing pre and post vital signs for everyone. It used to be several years ago that vital signs weren't even something that we need to collect, and then it was please collect at least the pre or the prior, and now we're being asked to collect both. This is actually a really good thing. I don't know how, even for patients who are stable, it's always very good to check their vital signs. And we also almost always want to know what the effects of therapy were. So always good to check a post vital signs to kind of see what change, if any, were there on the effects of the treatment. Don't forget to gather temperature here. Very important that we get all the vital signs that are required. You'll notice that I did not document O2 saturations. The reason why is we have to make sure we have a doctor's order that's actually in the plan of care that the doctor signs for us to be able to document O2 saturations. I won't go into all the details as to why that is, but it is the case. All of the rest of these vital signs, including respiration, heart rate, blood pressure, and temperature, are all vital signs that we can check regardless of whether it's in the plan of care or not. But if we're dealing with a COPD or emphysema or a patient that has some sort of issue in which O2 saturation is needed, make sure you verify with the nurse or the home health agency involved that the O2 saturation was something that was the doctor signed off on us for us to be able to collect. And then once you do, then we can go ahead and collect pre and post and airway, how many liters of oxygen they were receiving, and then what route they were getting it in. Okay. Patient stage. This is subjective, so we get to the sector. We get to the actual SOAP note part here. Whatever gets documented here needs to be either something the patient told you or maybe your opinion based on something. So in this case, patient states she's tired from not getting a good night's sleep last night. That's subjective enough to go here. Sometimes we see therapists documenting very objective things here, and if it's objective, it needs to be further down here in the document. We'll get to that here in a few minutes. Physical assessment. This all needs to be documented. It needs to be accurate. If the patient's speech is within normal limits or normal, then it needs to be documented that. What we don't want to have is, a patient that is aphasic or, recently had a CVA and their speech is not normal and it says normal here. So this all needs to add up. If they are hard of hearing, we can't have within normal limits here. It needs to actually state hard of hearing. So just make sure this is all accurate and that it is patient specific. Edema, we only have the two options here. Present, if it is present, then it leads into another spot here where it's dependent or pitting, and then location. For a lot of patients, it's absent. So that's the two differences there between the two. So absent. We don't really ever do a psychiatric worksheet. If we are asked to do one of those, or if that's in a yellow or purple note for you, make sure you call the office before you actually fill this out. It's a lot of extra busy work here that we want to definitely make sure we go over with you first before you do it. Documenting pain. This is the section for pain. We've got a spot for two different locations: location 1, location 2, intensity for the second one, intensity for the first one. What increases the pain, what relieves the pain, and what does it interfere with? Very important that if you're going to document pain, that you actually document these next three things. You can't just say, back pain in the lumbar region, 5 out of 10 pain, and then leave all of this blank. It needs to be filled in. What makes it worse, what makes it better, and what is it interfering with? When we get down to the range of motion and strengthening portion of the evaluation, a couple of different flavors or different thoughts here. You can leave these sections blank if you did not test for them, but as we meet with Medicare auditors and we meet with people who look at this stuff on a consistent basis, historically leaving anything blank is a bad idea. That goes for documenting OASISes, treatments, evaluations. Any time there's a section, it needs to be at least addressed. And so about the only time it's really appropriate to leave this section blank is when we have a dual discipline patient, a PT and OT patient, where OT's out there. If OT's out there, I more than likely will leave this section blank because I don't want my scores to interfere with their scores. And so, but if it is a single discipline patient, I think it's good to do some gross measurements. And then if everything checks out to be within normal limits, just put that here. And then when we're dealing with the lower extremities, this is kind of where we have our strengthening deficits. This patient scored a gross score of 4 minus for all the areas collected in the lower extremities. So now we're getting down into the FEM scores here. Very important that if the patient's modified independent to independent, then this blank here can be left blank. If you put anything other than modified independent, if you use standby assist, contact guard, min assist, anything better than, I'm going to hover over it, independent with equipment, independent, even independent with equipment on down through dependent, we need to make sure that we are putting in the factors that are contributing to why there's an impairment. And so in this situation, patient unable to ambulate without rolling walker, requires min assist for safety. Patient displays gait abnormalities, including short step length and foot clearance bilaterally. So we just can't put down min assist 100 feet and then leave this blank. That is an incomplete document. Same thing here for transfers. They were min assist, requiring a rolling walker for assistance, and struggles due to deconditioning. If they have a wheelchair or if they use a wheelchair, this is where we would want to fill that section out. Here we could absolutely just put NA for thoroughness if we wanted to, just to make sure, once again, that nobody could say, calls into question and say, we forgot to document it. Balance, whichever applies, able to assume midline and maintain it, able to maintain midline. Getting into the actual special test, this is a section that's become more and more under scrutiny. This is a perfect section for us to be able to display why we as therapists are needed out there. If we just say they have a strengthening deficit, or if we just say they need help with transfers, we're flirting a line on whether a caregiver or a home exercise program could not just do what we're doing. But when we technically do a Tenetti's, or we do even something as plain as a timed up and go, and then we give an objective score to that, we're now reaching a different part of care that we're getting into, where the physical therapist, with the level of education they have, by and large, that's doctorate or master level education degree, that type of special education is required to make this patient improve and to be able to document it objectively. And so using these specialized tests is very important. Sometimes we get evaluations submitted where there's not anything here. I highly discourage that. I think it's very important to have at least one, maybe two, even sometimes three specialized tests that we're using. It also makes our goal writing a lot easier and makes the note look a lot more evidence-based and legitimate. So DME, all the DME that they need, here's some of it pre-filled out for us. If there's something missing here, you can always put it underneath other. Let's say it's a Hoyer lift or whatever it is you want to put underneath other. And then anything they need, you put it in here, but this is not sufficient enough if you really want them to have it. If they need a single point cane, you're going to want to call either our office or the home health agency directly and let them know for any equipment that you think they need. This is kind of a free text summary of what we found during our evaluation, just kind of a breakdown of what we saw when we went out there. I won't read it out loud, but you can pause the video and read this and give you a good example of what the minimum really is. There's a lot more we could say about a patient. For the purposes of making this video, I try to keep it as generic as possible and as minimal as possible. And so if you're looking down and wanting to know whether this is a lot of content or a little content, this is actually an evaluation with the minimum amount of content that we want on an evaluation. You could absolutely add more if you wanted to apply it to the patient. So moving on to the treatment and goals, what's very important here are that the goals actually are functional. So we're not just saying increase bilateral strength to 4+ out of 5 and then leaving it there. We need to say why. So we're increasing bilateral extremity strength to 4+ out of 5 to improve independence with transfers to standing. That second part is very important. When people are auditing these notes, they want to know that we have a goal, that the goal is objective and that it actually gets to something related to this patient specifically. These treatment goals should play right back into this section up here at the top, dealing with prior level of function and patient goals. They all three go together. This is where they were at before the injury or setback or hospitalization. This is the generic version of the patient's goals. This section down here are our skilled goals that are obviously a lot more objective than a patient's goals, but they all tie together. They should all make sense when it's all read together in one document. Another required part here is that the time frames actually delineate between a short-term goal and a long-term goal. So whether your time frames for short-term goals are 2 weeks and your long-term goals are 4 weeks or vice versa, the time frame in weeks is not nearly as important. What is important is that you actually state that your first time frame is a short-term goal and your second time frame is a long-term goal. So these could actually be 2 weeks, 2 weeks, 2 weeks, 4 weeks, and 4 weeks. In this situation, you want this time frame to add up to this frequency. So, this is just an example, but this is actually done incorrectly. I've got a frequency here of a 1 week 1, 2 week 8, and I only have goals actually going out 6 weeks. So I'm going to change that to 8 weeks. And at least then I've met the minimum standard of saying, okay, I've got short-term goals and long-term goals, and I have at least one goal that I'm planning on it taking the full frequency to meet. You can't have 2 week and 4 week goals and then down here have an 8 week frequency. The two don't add up. So you want to have everything once it's being read, once again, to all make sense and add up. And so LTG and STG are required, literally, that you can write it out, short-term goal or long-term goal, or you can use the abbreviation, but it needs to literally be just like this in the time frames. Looking at another goal here, become independent with home exercise program, and then you ask why. Well, the why is for long-term functional stability. So here's the goal and why, okay? And so that wraps up treatment goal section. Treatment plan, Kinzer makes it very easy on us. They allow just literally a checkbox section. If there's something you want to add in the comments here, you're more than welcome to add in more detail. If it is a total knee patient and we have a CPM, we definitely need to click this box and then write down what we set the CPM machine to be. We very rarely use modalities, but if you do, once again, if you're going to do, a big time no-no would be to be using some sort of modality, whether it's iontophoresis or TENS unit, E-stim, hot and cold packs, even biofreeze. If you're using a modality and this is not checked, if it's not checked and the doctor didn't sign it, then we're outside of the plan of care on that in that case. And so if there's a modality that's being planned to be used at all during that treatment, during that episode or frequency, it needs to be checked and then documented here. Care coordination. This is a huge section that falls under a lot of scrutiny with Medicare. We definitely, even in our company situation where we've got a lot of therapists, a lot of assistants, a lot of moving parts, and sometimes you don't know, or a lot of times you may not know who is going to be treating this patient through the duration of the care. You can always put down supervisor notified. In the other section, you can write in scheduler, or you can always put down the administrator's name. In this case, it's Bridget Kress. You can always put down her and just put down and click supervisor. If you're in a territory where you know the PTA that's going to be treating this patient, then it's okay to actually write it in here and then check, the PTA and the box and go from there. And then what it's regarding to, you can leave it generic here, plan of care and goals. If it's something more specific, feel free to write that in. This box always has to be checked. I'm going to click it, uncheck it, and check it a few times. It's a little confusing for therapists sometimes. They think that if they didn't call right now, that if they didn't do it right now, that they can't check this box. And that's actually not what this box is meant for. What this box is saying is, was the physician notified of the plan of care, goals, frequency, and duration ever? Were they ever notified of it? And the answer to that is 100% yes. They are always notified, whether it's fax, phone, It does sometimes the home health agencies will actually send this through an electronic portal, but every one of these PT evaluations have to have the doctor's signature on it. And for that to happen, the doctor has to have been presented with this evaluation. So although we are not calling it in a lot of cases right there in the patient's home, and we may not be calling it in after we're done with the evaluation, which you are more than welcome to do. You can always call in your frequencies from the patient's house. Some agencies would rather do it for themselves, but it's well within your right to call on your frequency. A lot of therapists don't do it, and that's actually okay in a lot of instances because the home health agency is going to do it on our behalf, but we have to make sure this box is always checked. By leaving it unchecked, the way this document presents is we did this evaluation and we did not notify the physician, which never happens. There's another discipline that you're recommending, so this is the PT evaluation. If we're recommending OT, ST, or MSW, you check the box here there and you write in the reason why. This would be your physical way of requesting another discipline. You should not assume that because you documented it here that actually means it's going to get done. I absolutely would call it in. So if I'm out there and I'm doing a PT evaluation and I see a lot of need for OT to be out there, I would check this box, write the reason in, and then I would absolutely call the home health agency and tell them. I would tell the case manager over this patient that what you wrote here, requesting OT and the reasons why. Kinzer has made it pretty easy for us over the last few years. They've made this a dichotomous yes or no options here. So statement of rehab potential. If we're going to see them for therapy, obviously we're planning on their rehab potential to improve. And so patient has the potential to benefit from interventions provided. The answer is always yes. Treatment, skilled intervention this visit. We used to have to document completion of this evaluation and development of this plan of care. We used to have that to be documented somewhere in this section right here. It would have to be either indirectly or directly said, but there were too many notes that were being denied from Medicare, so Kinzer added this portion in just to make it very simple and very direct. Click the box, completed the evaluation and development of plan of care. Frequency, you probably either know this already or you will be taught in a different training video or training session. Episodes are always 60 days long in home health. The effective date always needs to fall within inside of these dates. If they don't, we're going to have to submit it back to you and get it corrected. Kinzer has a little pop-up calendar here to make it easy for you to plot your evaluation, your frequencies. So I saw this on November 1st. I can count and say I want to see them through the duration of this episode. So I count 1, 2, 3, 4, 5, 6, 7, 8 weeks. And so I get a 1 week 1 and a 2 week 8. And that's what allows me to go through the calendar. So you don't need to actually have a physical calendar in your hand to be able to do this. You can use it right from the software, pull a calendar up and figure out how you want to plot your visits and how many times you want them seen. Underneath discharge plan, it's very important that even at the time of evaluation that we document what the discharge plan is. Once again, very simple here to self-care, or if let's say you've got a total knee or total hip and from the referral from the home health agency that the patient's going to be going to outpatient upon completing a 3-week 4 in home health, then you can click this box too. Or you can click any of these that apply. But we need to make sure it's required that we do some sort of discharge planning in the very beginning. Now, let's say that we've done this evaluation, and this is one of the very first few evaluations that we've done while working for us, and you like it and you want to save it. It's, I like to save the ones that are fairly generic. If I've got a patient that's got a very rare diagnoses or they've got a real kind of one-off situation, I may not save that one as a template. But if I've got, say, a 3-day post-op total knee replacement, I may see a couple of hundred of those over the next few years. So I'm going to save the first one. So what I would do, let's assume for the sake of this evaluation, this was a total knee. I would click this box, save as a template, and write in, let's say this was a left TKR. I would save this as a left total knee replacement and hit save. And then all the information that I've documented would be saved in a template as left total knee replacement. And then the next time I had a patient that fit the vast majority of what I wrote in today, I could open my templates at the very top, pick my left total knee replacement, and then it would pre-fill everything that we documented today on this visit. And so that's a very useful, helpful tool. Would highly encourage you to be able to save as many templates as you possibly can, and document in a fashion in which your templates are useful and can be saved. A lot of these nuances, like making sure we write in short-term goal, long-term goal. If you're using templates and all your templates have it in there, it's very easy to remember, obviously, to do it, because you're not remembering anything. You're just cutting and pasting. But if you're a therapist that says, no, I want to document everything from scratch on every evaluation, there's the reason why we're not a proponent of that is because there's so many nuances that could be forgotten. Like, for instance, just writing in 4 and 6 weeks here instead of writing in short-term goal, long-term goal. Just forgetting that one thing would cause us to have to send it back to you, tell you what the corrections are, make the corrections, submit it back to us. There's all this administrative time and then time taken out of your schedule. Whereas if we just had, say, 10 or so templates that we used, and all the goals were written with this format, then as you use templates, you would never have to remember to do this. It would always be done for you. So that's just a helpful reason to use your templates. And this is how you save your templates here at the bottom. Once we get done, you type in your electronic signature, which you would have established when you first came on, and then you submit your documents. I may have a few more extra functions down here at the bottom. Don't worry about that. But just you always submit it, and then once it's submitted, it goes to our quality check department, our QA team. And they will quality check this evaluation for any errors, mistakes, things that need to be changed. And if there is, then what they do is they submit it back to you with a note attached to it, an electronic note attached to it that tells you about all the corrections that we need to get made before we can actually submit it to billing. And so I encourage you to always do your documentation in the patient's home. Sometimes there's going to be events that it's just not applicable. It just can't be done completely in the home. In those cases, I would not let that physical day lapse before I completed the documentation. I would not wait 24 hours to complete my documentation. There's several reasons why. One of which is generally the dates start to not match up. You saw them on a Tuesday. The date was the schedule was plotted for a Tuesday, but you completed your documentation on Wednesday or Thursday, and therefore your signature date. Let's say I started this evaluation on 11/1, and then I completed on 11/2. On 11/2, I may submit an 11/2 date. Well, now my dates don't match up, and so that's one little reason. There's several other very good reasons to always document in the patient's home and to get your documentation submitted as quickly as possible, especially with evaluations, but even with daily notes. And so I'm going to submit this, and let me not do this. It says I already have a left total knee. I'm glad I caught that, because I don't want this to be saved as left total knee because it's not one. So I'm going to uncheck that and hit submit. And then once I do that, my hot box will show that it's missing. And once it's missing, that's my way of knowing that it's not in my workflow anymore, and that it's now in the front office's hands to quality check. So if you have any questions about this video, you can always feel free to reach out to me by Voxer, text, phone.